Thank you, Monica. Our next presentation coming from India, and Usha, this will be done by the Usha Radhakrishnan, and the topic is Women's Insight into Obstacle in Cervical Cancer Screening, Experience from Family Planning Association of India. Usha is currently the Director of Monitoring Evaluation at the Family Planning Association of India, Mumbai, and she is having more than 22 years of experience in social and public health data management, research and monitoring and evaluation. She has played a pivotal role in various research projects and large-scale surveys, including the National Family Health Survey 3, collaborating with esteemed institutions such as International Institute for Population Sciences and the Tata Institute of Social Sciences. It is over to you, Usha.
Moving on to the introduction, cervical health is the crucial it is very crucial for the overall well-being of a woman, and which is neglected at most of the times. And cervical cancer is one of the leading cause of cancer-related deaths among women, and early detection will prevent 70 to 80% of cervical cancer cases. But though it is diagnosed at the last stage, most of these cases are diagnosed at the stage 3 or 4. Cervical cancer is the fourth most common cancer in worldwide, but in India it is the second common cancer next to breast cancer. And when we look at the WHO strategy 90-70-90, the 70% of the women will be vaccinated, will be screened by 2030. And when we look at the latest data, National Family Health Survey 2019 to 21, only 1.2% of the women were screened, but which is very high in other some of the BRIC countries and US. In US and UK, it is about more than 70%, and in Russia, it is about 93%. But in India, it is very low, 1.2% only. So it is significantly low in India. That's why the objective of this study is to explore the factors which deter women from undergoing cervical cancer screening in the operational areas of FPI India. We have taken survey statistics in 2023 from the FPI clinics. So Family Planning Association of India is a member association of IPPF and operates 45 branches and projects. And we initiated cervical cancer screening in 2013. And in 2023, we have provided more than 20,000 cervical cancer screening to the marginalized and underserved communities. So this is a qualitative study, and we have taken in-depth interviews from counselor, program staff, and outreach staff. So we have interviewed our FPI staff who are part of the implementing the program, and thematic analysis was carried out. Coming to the profile of the clients, it is actually the women in the age group 30 to 50 years. They were screened, and the high-risk cases, based on the history, they were screened. So our data indicates that while talking to there is stigma associated with the word cancer. So when they hear the word cancer, they feel something and they don't want to go the cervical cancer screening. There is shyness and anxiety about the gynecological exam, fear of pain, discomfort, concerns, last minute anxiety on the table. So that's why 1 to 2% it is stated that they just refuse to undergo cervical cancer screening. And most of our staff explained that fear about consequences of positive result and family communities response, treatment options and affordability are the major concerns among women for not undergoing cervical cancer screening. And also access to tertiary care and transportation issues, privacy and confidentiality in outreach settings. That is also mentioned by few of our staff. And resistance from male family members. So, because the religious and cultural things, and men are not cooperative in allowing the female members in their household to undergo cervical cancer screening. Also, when we are using AI-enabled devices, there is a fear that because it takes visual images, it may be leaked in the social media. That is also some concern.
Our next presenter is Dr. Monica Diama. She is going to present her research titled Prevention, Awareness and Early Detection of Breast Cancer Using iBreast Exam Device, an observational study by Family Planning Association India. Dr. Monica is a medical officer at the Family Planning Association of India in Pune with 8 years of experience in the development sector. She holds a master's degree in public health and postgraduate diploma in applied epidemiology. Dr. Dharma has extensive expertise in health programs focusing on maternal, neonatal and child health, family planning, sexual and reproductive health, HIV/AIDS and malnutrition. Currently, she works in the urban slums of Pune, addressing issues such as access to contraception, safe abortion, maternal health, adolescent health, infertility, and cancer screening. Dr. Monica Howard.
Now coming to the introduction, as we all know that the worldwide breast cancer has been a challenging public health problem. In India, in 2023, around 220,000 new cases of breast cancer were found. Approximately 70% of the women are diagnosed with the breast cancer in the late stages. And awareness and early detection of the breast cancer is still a lacuna, and to overcome this, the Family Planning Association of India Pune branch conducted an observational study in the urban slums, and to facilitate this, iBreast exam device has been introduced in 2023 September. The objective of my study was to determine the feasibility of deploying iBreast exam device in the outreach setting for breast cancer screening in the urban slums. Now coming to the iBreast exam device, it is ultra portable handy device for breast cancer screening. It is painless and radiation free, and that is very good advantage of this device. And it is one of the best tools to be used in the low resource setting, especially the primary health workers, to identify the breast lumps. It is designed to detect the early breast cancer symptoms, and it gives result within a minute. The methodology I used for my study was cross-sectional, observational, and the iBreast exam device was used for the women with age 20 to 60 years. And total sample collected were 164, and prior informed consent was taken of all the women. And this study was from October 2023 to March 2024, and a structured questionnaire was administration to the women with or without the complaint. The exclusion criteria was pregnant women and the lactating mother, information about the family history, previous lump pain, nipple discharge, and any previous hormonal medication was taken. This is the consent form. It was, we make ensure that all the women get their prior consent before the examination. The results were, out of the 164 women, 14 women were found with the abnormal findings, 10 were in the early reproductive age, 23 to 34, and 4 were in premenopausal age, 45 to 56. All 14 were further referred for sonomammography, And of these 14, 6 have been confirmed to have clinical relevant breast lesions, and we are still awaiting result for the remaining 8 women because some of them have moved to some other places, and due to some personal reasons, some women were not able to go for the sonomamography. And for during this study period, malignancy was not detected. But I would like to add one thing in this. In this October 2024, 2 cases of the breast cancer, 3rd stage, have been detected, and they are seeking treatment in the private and public sector. This is the, we can see this is the clinical diagnosis report. For the confidentiality, I have hidden the name, age and the number. These are the eye breast findings. We can see in both the images that it detects the lesion, minor lesions also detected. These are the same findings of the different clients coming for the screening. Now coming to the conclusion, the eye breast device is an effective screening tool for the early detection in low resource setting because of its portability, non-invasiveness and easy to use. And community-based screening increases early detection. And there is a need to encourage more and more women to come forward for the screening. And counseling pre and post plays a vital role for the further evaluation and management. Now coming to the recommendation, we should establish a follow-up system with the community health workers, and community health awareness program on a mass level should be conducted, and door-to-door breast screening campaign should also be a part of this. And we should also strengthen the referral and the follow-up system. Proper monitoring and evaluation of the screening outcome is important, and the acceptance of breast cancer diagnosis and intentional delay are the substantial issue which needs attention. These are some glimpses of our MCV medical clinic van. These references I used for my study.
And our next presenter also from India, and the topic is overcoming barriers to cancer screening, lessons from an integrated health service. This will be done by Neelam Dixit. She is a postgraduate with MA and serves as a branch manager at the Valier Family Planning Association of India. With over 3 decades of experience in social welfare, she specializes in empowering marginalized women and girls to exercise their sexual and reproductive health rights while also promoting their economic empowerment. It's over to you.
This is introduction and background. Cervical and breast cancer pose significant health challenges in India, contributing to cancer-related morbidity and mortality. As per NFHS 5, 2019 to 21, only 1.9% of women aged 30 to 49 years had ever undergone cervical cancer screening with breast examination at a mere 0.9%. Low screening rates due to socio-economic status, education, tobacco use, cultural barrier, lack of awareness, shortage of healthcare infrastructure, and trained personnel. When detected at an early stage, cure rates are high and require less intensive treatment, resulting in better quality of life and reduced healthcare cost. My objective is to integration of cancer screening into the existing SRH health services to improve access of cancer prevention among women, to reduce diseases burden and to save lives. Methodology: multifaceted approach targeting various aspects of cervical cancer prevention, such as capacity building of healthcare provider in screening techniques, visual inspections with acetic acid and cervical breast examination. Awareness raising campaign into the outreach targeting women in rural and urban areas. Counseling, providing screening and treatment services. Good communication and proper referral procedures. Collaboration with local cancer hospital for referral for women requiring further investigation or treatment. building rapport and trust with vulnerable groups, and reaching out to them through peer educators, robust testing for tracking for positive cases for referrals.
Our final present for this session is Dr. Ratnamala Desai. She will be presenting her research titled Collaborative Approaches for Eliminating Cervical Cancer in Rural Communities. Evidence from Dharwad District, Karnataka, India. Dr. Ratnamala Desai is a principal of SDM College of Medical Sciences, Dharwad, Karnataka, India. She is the president of the Family Planning Association India and member of the Board of Trustees of International Planned Parenthood Federation. Dr. Ratnamala, over.
India is a large country with a huge population, and we do not have free vaccine. I understand that Sri Lanka has got free vaccination for HPV vaccine, but we do not have free vaccination. However, our finance minister did promise in the last budget that they would provide a separate allocation of budget for HPV vaccine, but it has not yet materialized. So we have to procure vaccine, and then we have to give it. And as you know, FPI is an NGO, and we work in 40 centers across India. And we are providing contraceptive services. Other than that, we also are doing cancer screening. And also we are planning to give a complete treatment like vaccination, screening, and treatment of pre-invasive lesions. The first step for us is to mobilize resources to procure the vaccination. And who are our donors? Our donors are the corporate sector, where they give their corporate social responsibility. As a part of that budget, they give us money. The NGOs like Rotary, and of course, certain community leaders who give us donation. Now, it's not enough that we procure the vaccine. When we go to the village, the people, the parents, they are not very forthcoming to accept the vaccine, even though we are ready to give it as free. And when we go to the schools, it is a different story, because there we need parents' consent. So the parents are not there in the school, and teachers are not ready to take the responsibility, and they should not be also, but they ask for too many permissions. So we have had difficulty in working in schools as well. So what we have done is that not only we got donations from the corporate sector and the community leaders, but our workers went into the field and they created awareness among the public, among the parents, amongst the community leaders, among the panchayat leaders, explained to them what is cancer cervix, what are the consequences of cancer cervix, and how you could prevent cancer cervix. So we involved the community in educating them and creating awareness, and that's how we could get their children to come and get the vaccination. So what we did was, the healthcare providers, the community leaders, the parents, together, all are a part of this program. All are part of this program where we involved everybody to create awareness and to prevent cancer cervix by giving vaccination, and to screen the women. So not only we vaccinated children from 9 to 14 years, but we asked the mothers to come along with those children. So the mothers were screened and the children were vaccinated. And not only with that, when we screened the mothers, whenever there was a pre-invasive lesion, we took them to our hospital, took them to our clinic, and treated these by colposcopy directed biopsy, or a cryo, whatever was required. So we completed the circle in the sense we gave vaccination, we screened the mother, and treated the pre-invasive lesions. So here we try to do what the WHO recommended, that you have to vaccinate 90% of the women, we have to 90% of the children you have to vaccinate, 70% of them have to be screened, and 90% have to be treated. So here I would like to give one example of one village where our healthcare workers went to explain to them. We had procured the vaccine by a corporate sector. We went to that village, we talked to them, we gave them health awareness, but there was not much of a response from the community. Then we talked to the community leaders, the panchayat president and the panchayat members. And then the panchayat president took the responsibility to go to each and every house and explain to them the advantage of getting the vaccine, which was being given free of cost. And the next day, the panchayat leader himself sponsored for 80 girls to give the vaccine. We gave the vaccine for 80 girls by the sponsorship of the panchayat leader, but then another 14 girls came. Then we didn't know what to do. But the remaining 15 members of the panchayat agreed to sponsor these children. And then we had screened all those women in that village for precancerous lesions. And then we treated about 7 of them, and we declared this village as a cancer-free village, cervical cancer-free village. So this is how Family Planning Association of India is working, where we are trying to give vaccination, where we are trying to detect precancerous lesions and also treat the precancerous lesions. Thank you so much.